Describe
Why?
grand rounds.
I'm gonna check because we can start early voting I think next week.
Because of the COVID prescriptions, our normal visiting professor program is contracted down to grand rounds format, and it's actually a loss for us because we usually have internationally renowned speakers, personalities like Dr. Liu, who comes and spends the day with our cardiology fellows, which is a great treat for everyone, get to learn about the person more than just by a lecture. But because of, unfortunately, the COVID pandemic, we're restricted by GME and New York State about traveling. So instead, we are privileged to have Dr. Liu by Zoom. I actually asked Dr. Jeff Mechanic to introduce him. Jeff Mechanic, as people know, is an endocrinologist. But Dr. Fuster had the insight and foresight to recruit him to head our cardiovascular wellness center. Jeff is world-renowned, a leading figure in endocrinology, has written many of the guidelines for which we treat patients in cardiology. And believe it or not, the synergy between an endocrinologist who is skilled as Jeff is in dealing with diabetes, hypertension, obesity, smoking, but has a phenomenal bedside manner, is a great opportunity for our fellows to learn about managing patients with those problems, as well as prevention of developing those problems. So it's really been a tremendous honor and privilege for our cardiology fellows to work with Jeff. We're privileged to have Jeff on our faculty and as a teacher and as a mentor to our fellows. With that brief introduction, I could go on and longer. I'll ask Dr. Mechanic to introduce our visiting speaker today. Jeff, thank you very much.
Great, thank you, Marty. Thanks, everybody, and good morning. Welcome, Simin. Dr. Liu is a physician scientist. He's an epidemiologist. He's going to be speaking on global cardiometabolic health. His research has been in a lot of novel dietary, genetic, biochemical markers for not only cardiometabolic, but a variety of chronic diseases. After his faculty positions at UCLA and Harvard, he became professor of epidemiology at the School of Public Health. He's also professor of medicine and endocrinology and professor of surgery at the Albert School of Medicine at Brown University. In addition, director of the Center for Global Cardiometabolic Health at Brown and adjunct professorships at Harvard and also in the Chinese Academy of Medical Sciences. Now, most notably, his accomplishments are publications in JAMA, New England Journal, Lancet, and many other very high-impact journals. His group was the first to identify that SHBG, sex hormone binding globulin gene, was a causal determinant for type 2 diabetes risk in a lot of different ethnicities, races, and this opened up new preventive strategies for cardiometabolic cardiovascular diseases. He has over 400 original publications, and including editorials and also some proceedings, over 170 international invited lectures, PI of 3 R01s investigating environmental, nutritional, and genetic markers for diabetes, obesity, and cardiovascular disease, not only in the US, but also in China, Brazil, and most recently in Ghana. It's had some recent reports there. Mentored over 100 trainees, raised funds for them, developed several novel transdisciplinary training programs, including the Genomic and Nutrition Program and Burroughs Wellcome Fund Interschool Training Program in Metabolic Diseases at UCLA, and the Global Cardiometabolic Health Program at Brown. In 2019-2020, he was awarded the Presidential Fulbright Commission by the Fulbright Commission as the first U.S. Distinguished Chair in Global Cardiometabolic Health. Above all else, Simon's a good friend and colleague. And now, Simin, the Zoom is yours.
Well, thank you very much, Jeff and Dr. Goldman, first for both the kind invitation and introduction. It's an honor to be with you and to share with colleagues, particularly the fellows, some of our works and ideas concerning global cardiometabolic health at Mount Sinai. See if I can move. Great. So I do have some disclosures. We should be an open book professionally, which I subscribe to the idea. In fact, you can download an entire copy of my CV at Brown's website, updated every year. I also wanted to acknowledge at the outset some of the main funding supports and my colleagues and I have received over the years. It's safe to say that without all these participants and colleagues and trainees in this space, today's seminar is not possible. And I would cover some of the works that you probably have seen. I spent a lot of time working on the Women's Health Initiative, some of the work from the Framingham R study, and more recently, the TopMed and the UK Biobank data, along with traditionally the Women's Health, the National Enhanced data. And our work, aside from really is mainly supported by, as Jeff alluded to, NIH R1s, but also supported by contracts and some of the related private donations and whatnot. I want to start by sort of introducing these three books. One is to the left, it's the impactful report from the IOM committee chaired by Dr. Fuster back in 2010. To me, as most of you know, that Dr. Fuster's visionary leadership has sort of inspired many, including my own works in this area. And to some extent, my talk would be a progress report. And I wanted to take the audience from the second report here, given out by Dr. Gibbon, the director of NHLBI in 2020, where he highlighted some of our own works to show how this journey is from nucleotide to neighborhood, and how we could have, as physician scientists, delve into each one of those areas and taking a system approach to discovery and have high impact to both individual and population health. And the third one, of course, is from my good friend and mentor, Jeff, and Jeff's leadership, which is really remarkable in many respects. And the reason why I highlight this book is that the book that perhaps my contribution have held up the book's publication a bit this past year due to my sabbatical serving on the Fulbright mission in China. But nevertheless, the book really is, for the first time in my view, can allow sort of like saving what we call a academic orphanage in preventive care, particularly in academic medicines, and managing chronic disease in the United States, and how successfully some of those experienced and summarized in this book, which is really just arrived on my desk about a week ago. So if I ran out of time today for my sort of some of my works, really is as a progress report from Fuster's report to the mechanics book. I would highly recommend it. These three reports contain much of the information I want to cover, but I have to select it given the interest of time. Now, this figure nicely summarized much of the accomplishments in medicines and public health in the 20th centuries, particularly concerning cardiovascular health. And we all know that lifespans has increased by almost 50% now in the past 50 years, largely have to do with the success of our cardiovascular health professions. And we should take pride in these accomplishments. From the peaks in the 1960s for cardiovascular mortality has been reduced by now by 75%. Right, this remarkable progress in biomedical science and technologies, particularly as they were brought to bear on clinical management of CVD, which also increase some of our fellows' training durations. One should not forget some of the population strategies also contributed to the reductions in the burdens of CVD in population. And it is important to know where we come from and claim victories when victory credits are due. Yet at the same time, we have to think about some of the epidemiological transitions that's happening. I think it's safe to say from evidence-based perspective that now all, or at least majority of the risk factor for CVD have been identified in high-income regions. And effective intervention and controls are available. And in fact, our own works have, our own modeling have shown, based on multiple large prospective cohort studies, high quality ones conducted in the United States and Europe, 80 to 90% of the cardiometabolic disease can be prevented via lifestyle and dietary interventions. And this this reducing or reduction in total mortality, particularly mortalities in CVD, has continued at a rate of about 2 to 3% per year, and now, until now, which leads to roughly 10 years ago, the AHA's goal of saving 1 million hearts by the simple ABCD or Life Simple 7 strategies. And yet, why does CVD remain the leading cause of death? And can we end the epidemics of cardiovascular disease by 2030, 2040, or 2050, 1 century after it's emerged as mankind's #1 killer? Some of these kind of big questions, unfortunately, lost in translation. We tend not to ask this kind of question anymore, and focus relevant efforts and resources on what matters. Why? You say that we cannot claim complete victory where we already know the trend is going down. I think this is, if you look at the AHA Simple 7, here is the Simple 7 here. The adherence to this Simple 7 is indeed difficult to achieve, particularly concerning adoption of a healthy diet. This sort of like these big questions and focus, you can see 78% of the dietary practices are considered still unhealthy. Add to this complex challenge in the bottleneck in cardiovascular health promotion is also the steady rise in obviously CVD burden around the world. You see the transition of for some reason, I can't see my slides. Again, this is one of those zooms that happened, the connection. Can you guys see my slides?
Yes, we can.
Okay, great.
So if
you couldn't just yell out, so it's somewhat funny talking to the screen, although I know this past semesters we've been talking to the screens for a long time, zone in and zone out. But suffice it to say, the transition of the CVD burdens in the world have shifted from the west to the east. Show here is the latest sort of like age standardized tally called a disability adjusted life year in 2017. But now, in fact, just this past weekend, the Lancet produced yet another report from the GBD group that I was also involved in. The data show the disparity even bigger, ranging from 1.5 Ks to 14 Ks, literally tenfold differences in daily change across the world with those get most affected in the former Soviet Union. Hello, I hear some noise. You can never tell.
You've changed screen. Now we just see you and not your slides. And as Jeff says, you're nicely dressed.
Can you see it now?
We're good. Yeah.
Yeah, screen's back.
Great. Sorry about that. You know, you touch a button and all right. My apologies. But move on to, in fact, this kind of epidemiology transition is most concerning to the fifth transitions which led some of us, led by the US CDC, to coin the term of epidemic of our times. Globally, particularly for diabetes, you see now we have nearly 500 million with diabetes. In fact, half of those at the moment happen in China, India, and Southeast Asia. And 85% of them actually, many of, not 85% of them, like the projected increase was 84%. Now, this is projected to 2045. Yet the projected greatest projection in increase would be in Africa, not only in the northern and Middle East, Northern Africa, but particularly in sub-Saharan African. That's really the main concern for us. And most important of all, a lot of these diabetes are unrecognized. Half of them are unrecognized. So I think it's sufficient to say, to improve our understandings from molecule to population, we cannot just ignore some of the major macro factors that are environmental degradations, obviously globalizations, and explosion of information due to technologies that all the more reasons that leads to disparities. And these disparities would actually mandate us to look at traditional CVD risk factors in this macro context of both epidemiological as well as demographic transitions. And because of that, we might even discover novel risk factors if you consider interactions. And that's what I wanted to show some examples to illustrate my point, and using what I call the so-called 6 P's epidemiologies. P stand for prediction, precision, prevention, personalized, population, and policy, all which are cutting edge works led by folks in the United States, though we now have to apply this with this kind of research in these 6 domains to incorporate international, interdisciplinary, and focus on integration, innovation, and implementations. And I would also argue for those of us who are obviously in healthcare, we believe, or particularly in public health, we believe health really ought to be a right issue. But even for those of you who don't believe health is a right issue, at least just identify a common goods that we should all adhere to or strive for. And I would also, I hope, convince you that we need to do global health and approach it if we wanted to make causal inference appropriately to do the good science. Now, using the examples, this is also a conceptual frameworks that we have been adhered to look at the totality consistency and quality of the evidence, particularly dealing with all this demographic as well as epidemiology transition, this macro factor. And within this macro factors, we have to look into various risk factors concerning diet. And ultimately, we have to look at the consistency to make recommendations that would affect populations with policies, particularly with policies. For example, most of you might be aware of the so-called diet hypothesis, which has motivated much of the scientific works in the cardiometabolic space this past 60 years, both in terms of the quality and quantities. You would argue our consumption of intakes of dietary composition have changed from an evolutionary perspective. In fact, this data at a large trend can be identified also based on the GBD kind of works. And we now were able to, based on based on the World Bank, World Health Organization, as well as the FAO, called Food and Agriculture Organization database, that we can allow us to reconstruct all 204 countries' dietary nutrient database, and thus allow us to look at this more comprehensively to see some of the variations as it related to cardiometabolic outcome of interest, and highlight here one of the major change in human diet over time from an evolutionary perspective is dietary glycemic load. And I want to link this for those of you probably feel this is very familiar in the cardiometabolic price is the dietary fiber. Something as simple as dietary fiber, you may ask, in fact, that has been most consistently and prospectively associated with increased risk of heart disease. And yet within population level, looking at this, this one is published literally almost 2 decades ago in JACC. Now, because Dr. Fuster is the editor-in-chief, so I select out a couple of the papers, particularly from published in JACC, to illustrate this consistency of this work. This kind of data is now, it's actually being further illustrated with the recent data showing microbiota effects, essentially telling you that the nutrient that's provided to the colon that support the microbiota turn out to be important. And this is actually have some historical and geographical implications for diverse populations. Same thing with a simple measures of diet. One could also identify the opposite, which is the high fructose corn syrup data that indicate the importance of for cardiometabolic health. Now, why, in fact, this high fructose corn syrup hasn't been around that much, and why it turned out to be bad. And this is what lead us to, again, to think about some of the systematic issues as it related to clinical management of patient. The critical thinking is the food production process has, or fortunately or unfortunately, standardized our whole way of living. You could now classify carbohydrates as traditionally, for example, simple versus complex, and yet they are nutritional even with the same kind of chemical composition of complex carbohydrate. Because of these processes of production or refining process, you cannot even determine its ultimate physiological outcome unless you do some sort of bio assays to determine. Here, use a very simple qualifying biomarker called glucose or postprandial glucose to determine it. And then that's how we come up with the idea of a glycemic low from a diabetes management perspective, help to improve at least from the existing carbohydrate exchange list when we give advice to patients with diabetes. And it is increasingly important to incorporate this kind of idea, and without the constant surveillance of this kind of industrial process, one cannot really determine the biological or in vivo physiological effects of the diet consumed. That said, this is also our works to further show in the Nurses' Health study the interaction between diet with BMI and anyway, so does someone have a question? But it's actually better to show this slide so that folks can ask questions, and I really look forward to a more direct question and answer than talking to the screen. But that said, suffice it to show that this kind of interactions are not only happen between the dietary intakes and our simple body weight measurement, but also down to now we were able to measure the whole genome and assay, which then allow us to look at different kind of foods indeed by genotypes, and constantly and consistently we see many interactions identifiable that are indeed significant. And I'm just using a few examples here to show the glycemic low, which is a overall bioassay to measure dietary, one aspects of a standardized dietary intakes. As you can see, we see signals and everywhere. And this kind of signals can actually be detected if we do a clinical study to verify. I argue for internal consistency, showing now not only from the perspective of identify the particular genetic variant here, showing the red in this graph, is that some gene were actually identifiable only for folks with low intakes. Here we highlight here is the magnesium intakes, and the genes that govern the magnesium absorption process was identifiable. Whereas same thing in the small scale clinical supplemental trial, we could actually also identify significant changes due to a simple supplementation with a large array of gene changes, and then later be validated that in experimental works, the expressions of these two genes. Now, things like that are possible all the way really from neighborhood to nucleotide to trace these epidemics down to the molecular level. But for most important of all, however, I want to bring it back to this sort of like major context of transition, looking at the transitional risk factors in the context of the environmental degradations, and something literally as far back to the sort of like Hippocratic times, like for air. You look at this air, although one would argue that we already established based on the US data, some of the 5 particle matter like PM 2.5 has been associated somewhat controversially with the risk of heart disease. and still debatable. And yet, if you look at the world's map like this, you will see the major shift in the sort of like the dose response of this matter. If you continue to look at the PM 2.5 and trying to do within population study in the United States, it is relatively difficult to identify a significant relative risk. And yet, if you look at them from a global context, those risk factors literally jump out at you. And this is also an air sort of like showing literally a picture of this world's major manufacturer heartland now in the southern part of China, in the Old Canton area, or the so-called China Pearl River Delta, and now it's the world's #1 largest urban area, both in terms of size and population. And this is the picture I literally took last year. And the other side, it used to be really a beautiful patchy area, and now become the world's manufacturing center, and they also call it the Bay Area. And the rapid urbanization and the environmental destruction, which I will show in the interest of time, but I do want you to see this. It's just like smoking causes lung cancer or smoking causes heart disease. You do not even need a randomized trial to show this is actually unhealthy. And however, we wanted to provide some of the evidence. It's the very basic things in the air, in water that have changed quite significantly. So in a series of papers, this past 10 years, we have provided one of the first set of evidence directly linking these heavy pollutions of what we call endocrine disrupting chemicals and metal, or including heavy metal exposures across the land, to show them directly affect the risk of diabetes and related cardiometabolic outcomes of interest. And it's just very quickly, I will show you this, and folks still argue whether or not this is directly related to cardiovascular outcome of interest, though we are actually being funded to do this kind of works now in Brazil, as Jeff was alluded to, in Brazil, China, and also in the United States, where we can actually cover a very large variation for the first time to look at this, with the US being the lowest spectrums of exposure, where Brazil more intermediate, and China being the most highly exposed area, where it will allow us to truly establish some of the links, if any. But suffice it to say, this kind of data forces to think harder is whether or not the traditional risk factors, which we all sort of like have to memorize, really still play an important effect, particularly in the context of some of these emerging risk factors. If you consider interaction is the key point. I want you guys to sort of like take a look at these pictures. Much of those effects are actually very similar to the steroid in its chemical structure and its biological effects, presumably signal through either the estrogenic or androgenic pathways. And now, before I go deeper, I also wanted to remind everyone with some sort of classic data that show, as a way to summarize what I have attempting to do so far, is linking this sick individual and sick population by showing you that within one own individual population. So here is actually the Framingham heart study data. even for something that, as like I was alluded earlier about the classical diet hypothesis showing lipid or dietary cholesterol among those who with coronary disease versus those without coronary disease, the distribution are indeed quite overlap within the same population. And this kind of concept is extremely important for cardiologists, particularly those with the idea of prevention, to look to for potential understanding or devising policies to deal with this kind of phenomenon. If our ultimate benchmark is to lower the burden of cardiometabolic disease, one would have to look at this kind of population figure shown on the right here is the distribution between distribution of hypertension on systolic blood pressure measurements between Kenyan and the London civil servant. That is more than 5 decades ago. And what happened now, a lot of folks still do not know. I can show you that some of the data and that's what prompted us with some supports from foundations and the World Health Organizations completed a recent survey in Ghana. It's a national survey that we have attempted to do to provide some most comprehensive data without boring you with the gory details of the random stratified the three-stage random sampling strategy that we employ. We identified across the country over 1,000 individual where we provide fairly comprehensive assessments from the demographics, the medical history to physical exam and the traditional cardiovascular risk factors. Just very quickly to show you some of the data. This is about to appear by the Journal of American Heart Associations now. For the first time, we show, in fact, in many of the traditional or classical risk factor in this very representative sub-Saharan African population nationwide, some of the risk factors really is alarming, particularly for hypertension and obesity, as well as a major differences between the sexes is also alarming, showing very quickly now blood pressure with a left ventricular mass index, peripheral artery disease, carotid hypertrophy. Some of those just give you a sense of this data that we are now trying to follow up after the completions of the baseline assessments to understand better why there's such a major sex differences in this context. Now that would I also as I show earlier of that global map of the epidemics of obesity and diabetes projection, that's what brings us projection. The number one would be Africa, and yet there's another very interesting population in South America where we know very little about, and this is the works of the folks in Brazil, and then also to a large extent thanks to Dr. Fuster's IOM committee's impactful report, after which the NHLBI have started a global health program that sort of like established around 11 for the past 10, 15 years, established around 11 centers of chronic disease prevention and management centers across the globe with emphasis on cardiometabolic and chronic disease prevention and managements and build the capacities. And this is one of them growing out of Brazil, where for the first time they established a prospective cohort studies among civil servants in that country, which is really amazing because as we all know, the Brazilian population is highly a mix. Is actually genetically a unique, very unique populations allow us to understand gene environmental interactions in affecting cardiometabolic outcomes of interest. So this is the work I would show also very quickly to at least allow you, you to appreciate some of the work that that has been done for cardiometabolic risk factor, both traditional and some of the novel risk factor that identify, such as also sex differences, and also the differences even with the mixed population, showing the importance of some of the environmental exposure and the lack of control, particularly in the context of the lack of controls of traditional risk factors. Here is the CVD in black among diabetes. This is showing essentially the adherence of drug usage, even in controlling very important phenotype resistance hypertension. It's actually grossly inadequate in that population. Now, so we move from Asia to Africa and back to South America. And the whole idea is this showing you this population we are experiencing really in the low and middle income countries, a perfect storm of traditional CVD risk factors. And this is in the major context of cardiometabolic environmental degradations that are very conducive to what we have experienced in the West in the 20th century of essentially a pandemic. And now I would also argue, if you see the transitions, a lot of us think of the epidemiology transition as already few way past the infectious disease, the first stage of infectious disease and famine. But unfortunately, that was in my view, a misunderstanding or too optimistic way of understanding the improvement of demographic or epidemiology transition. Still in much of the world, particularly in the low and middle income country, or in fact, this year, we have experienced yet another infectious disease pandemic, namely the coronavirus, the SARS-CoV-2, that really I would sort of like spend some time later to sort of illustrate why the kind of social environmental substrates as it is really is fertile for the pandemic to hit. And again, the importance of interaction across different stage in the community, as well as across the globe. And that's the reason it is indeed important to make us think about policy. And as epidemiologists, we also feel extremely frustrated to some extent, realizing this discipline, even though has been heralded as the foundational science for population health, and yet can do very little, in fact, in affecting population outcomes. The point I wanted to make too is that this kind of stage, different kind of population transition effect could actually be extended to different generations. Now we have, for those of you in the molecular science, you are probably well informed with the concept of phenomenons of epigenetics effect, but in a human population, this kind of data are difficult to come by. But nevertheless, if you are, we were able to, in population that have experienced famine and completed studies that this is in the northern part of China, where in the 50s, in the late 1950s and early 60s, and experienced really the world's most detrimental famine that literally killed 20 to 30 million people. And for those who during famine, during the famine and after famine exposures, that population continue to be followed until including their and their families. So we were able to document this kind of transgenerational effects of famine on many of the well-established cardiometabolic risk factors, which again bring us back to some of the phenomena that have most consistently observed. I should also point out that there's major sex differences in this kind of observation as well. So the idea of these sex differences in cardiometabolic health has been well established or well observed in the West, summarized here in two very high impact reviews. We know that even obesity is the single most important risk factor for type 2 diabetes, for example, but it is stronger, if you look at the slope here, stronger in women than in men. And we also know that women are in general much more protective than men in terms of getting heart disease. But once they develop diabetes, they are actually at a greater risk of developing heart disease. And all this kind of observation would tie us back to what I showed earlier, some of the EDCs that signal through the estrogenic or androgenic pathways that lead to some of the changes in disease. Now, with the global data resources now, coupled with technology, we could now do the most comprehensive assessments all the way down at the genomic level across multiple populations. And this is one of the early works that, and this is actually based on the Women's Health Initiative data, doing a whole genome scan and for diabetes, and identify some of the very interesting genes of TBL1XR1, and also the progesterone receptors that are the most significant signal, at least in this data set. Now that what brought us to look at the sex hormone metabolism pathways, and I will show very quickly in the interest of time, and all the things that highlight in reds are what it passed the so-called FDR significance. So you can appreciate the multiple factors indeed in these pathways of a total of roughly about 32 genes that we look at that are directly predictive of diabetes risk. In fact, we look at this in both men and women that ultimately led us to zero in onto the SHBG genes that together in two functional mutation, Gemini mutation, that combine not only can predict the risk of type 2 diabetes, here is over roughly a 10-year period, but also directly and proportionally with the intermediate phenotype, the protein level detectable in blood, and led to some of the newer development. And this is the paper that published a while ago now, but I want to show is some of this because of the approach that we have taken, a global and comprehensive approach. When incorporating the technology, we were able to apply some of the Mendelian randomization, then a newer strategy to illustrate the causal relationship between this phenotype, this genotype, as well as phenotype. And then we subsequently follow up within multiple populations that to demonstrate it, this effects in African American, Hispanic American, as well as Asian Americans, showing the importance of this and reconcile to some extent some of the differences in between men and women. This is the recent works that just published on stroke, linking SHBG to stroke development, again highlighting the importance of this protein as almost a biomarker for the cumulative measures of all these environmental and genetic interactive effects. Now this is the data also published from published in JACC, showing here is another way to measure at the total testosterone and estradiol ratio, and somewhat of an interesting effect with different phenotypes of cardiovascular disease in MESA. Now,
it's Jeff Mechanic. Maybe we can try to wrap up in a couple minutes so we have 5 minutes for Q&A, okay?
Okay, so wait, okay, that's, thanks for pointing that out, Jeff. This is very helpful then to lead us reconstruct the understanding, as I mentioned many times in the traditional understandings of the risk factor for disease. Once we appreciate the interactive forces, the multiple interactive forces, along with the traditional risk factors, we could reconstruct some of the newer pathophysiological understanding, and even led to the identification of novel markers. So I would be remiss if I don't talk about the recent recent pandemic that we are all experiencing. The whole idea is to highlight the importance of population health based on policy. In fact, the leadership all the way at the top appear to be very important. And I showed earlier about the environmental degradation in air and in water. This is an example in China to show that after the GBD reports, they actually respond very quickly, and which, you know, we actually estimated the amount the lives that have been saved over 1.2 million, and over 25 million healthy years of life loss has been saved because simply they adopt this kind of a policy as well as behavioral change. And as you see in this picture, that's the reason why that kind of culture is actually much more acceptable in the East than in here. Now, I said I would be remiss if I don't talk about this, particularly in the social substrate or even for cardiometabolic disease. In fact, in the past 2 decades, we have experienced three major epidemics. One is obviously, I show in the Pearl River Delta region, the SARS-CoV-1, or you say, and the more recent in the Yangtze River Delta, the SARS-CoV-2. And even though apparently this is a virus, but it emerged from those environmental degradation, as well as human epidemiological transition. Now, the heart disease, another very interesting, why would some of the folks with COVID-19, you would ask, with poor outcomes? Why are those elderly men and those with chronic metabolic conditions tend to experience serious outcomes? And this is the data from 60-some countries, clearly demonstrating also sex differences. And this obviously have behavioral reasons, but some of which are also biological. That would allow us to, in fact, what we have learned based on data that have been collected or studies that have been done in the past few decades in high income countries, show here is 6 different kind of pathways linking low birth weight to insulin resistance and type 2 diabetes. Each one of those pathways could arguably be attacked or facilitate the attack of the virus in creating severe outcome for this COVID-19 pandemics. In fact, this analysis of the Wuhan experience shows whether or not or how good you manage those cardiometabolic risk factors before the pandemic hit, have also play a significant different roles in affecting the ultimate outcome of the disease. So I would just end with this summary. It's sort of like a major, obviously we have a major collision happening between our ancient genome and the modern environments. And because of those multiple interactive forces, risk assessment needs to be done in different population contexts of this transition. And we need to, don't forget, what are the ultimate benchmark in reducing these burdens of cardiometabolic disease, and how we can address using the technology to help us to address the burdens of the disease all the way using Dr. Gibbon's work from nucleotide to neighborhoods. And then don't forget, with the cardiologies, we should have a seat at the tables and remind ourselves the biggest question, the most impactful question we wanted to answer, which is, we actually know so much. Can we end the epidemics of cardiovascular disease in the 21st century? Thank you very much for your attention. I truly appreciate it. And I would really love to show up in person and interact with fellows and colleagues at Mount Sinai.
Great. Well, thank you, Simin. We really enjoyed it. Maybe we're right at the stopping point, but maybe if anybody has one question, Dr. Fuster, if you're on, any questions?
You'll have to unmute if you want to ask questions.
No, thank you. But it's a very interesting summary, and you made 3 summary comments in my view. One is that behavior that can be modified by understanding all the factors that intervene in education. The second is policy, and the third is pharmacology. Unfortunately, in the adult population, I have to say to you that at least it appears the policy may work. The tobacco is an example. Pharmacology can work. Statins is an example. But the change in behavior, even understanding the factors in education, I feel much more somewhat skeptical. And this is what led me, at least personally, to move completely into children. And that is,
Right.
can we modify the way they see the world by promoting health as a priority at very early age? It's just a comment, but I just like to compliment you and to thank you very much for your presentation. And just to add a final point, I think all of your understanding will be completely enhanced by machine learning and by artificial intelligence. We will understand the factors much better. Thank you.
Dr. Kruster, really it's been an honor, and I really truly appreciate it. This is my progress report, as I said earlier, to that committee report that you chair in 2010.
Thank you.
Terrific. Well, thank you. I think our time is up, unfortunately, but Simin.
Yeah, I'm sorry to take up too much time.
No, it was a wonderful talk. We thank you very much. Hopefully we can have you back. And with that, I would just like to wish everybody a good day. Thank you.
Thank you so much, Jeff. Thank you, Dr. Gorman. And truly it's a pleasure. And I hope we get used to more with the Zoom in and Zoom out.
Thank you
so much. It was fantastic. Thank you. Thank you, Jeff.
You're welcome.